Hi, my name is Brian José Lozoño Quijije, and today I'm going to talk about Adjuvant Sunitinib in high-risk renal cell carcinoma after nephrectomy. Okay, first we're going to talk about the definition of the topic. Sunitinib is a vascular endothelial growth factor pathway inhibitor. It's an effective treatment for metastatic renal cell carcinoma. We sought to determine the efficacy and safety of sunitinib in patients with locoregional renal cell carcinoma at high risk for tumor recurrence after nephrectomy.
Hi, my name is Dan Petrolak. I'm a professor of urology and medicine at the Smilow Cancer Center at Yale University. I talked today about the controversies in renal cell carcinoma, and we divided the talk into two different sections. First was the use of adjuvant TKIs in patients who have had high risk renal cell carcinoma after surgery. And what we concluded was the fact that these drugs have toxicity issues. There are no trials that have shown a survival benefit for either sunitinib, pazopanib, or sorafenib in this particular setting. So I think that what we need are better ways to define which patients should use these drugs. Should it be high risk, although the studies have shown no benefit for the high risk patients. And I think that importantly, sunitinib has been approved in this particular line of therapy. I think it's important that the physician have an informed discussion with the patient regarding the appropriateness of administering these drugs. The second portion of the talk was reviewing a recent study from the New England Journal of Medicine where patients were randomized to receive either sunitinib alone or sunitinib plus nephrectomy. And in contrast to data that Dr. Bob Flanagan presented a number of years ago, when patients with metastatic disease were treated with interferon or interferon plus nephrectomy, there was an improvement in survival for those patients who received sunitinib alone. Now, the question is whether this is applicable to all patients. The patients who had the best outcomes were those patients who were poor risk or intermediate risk. The question is whether this is applicable to those patients who are good risk, and we really don't know. The second question is, does this apply to immune therapy? We really don't have any good studies that have looked at nephrectomy prior to immune therapy for patients with metastatic disease. So I think there are some very, very important clinical questions that need to be asked based upon this data. And at this particular point, I think you need to have a discussion with the poor risk patients and the intermediate risk patients whether they should receive a nephrectomy if they're undergoing TKI therapy.
Now, issue applied in Ecuador. In Ecuador, this project is not available at the moment, but the government should develop it with scientists because it could improve the prognosis of patients with high-risk renal cell carcinoma after nephrectomy.
Clinically, when we're thinking about who to treat with sunitinib, we want to pick the patients we think are most likely to benefit. By enriching for these highest risk patients, we can really focus even further on the patients most likely to benefit. So when I see a patient in my clinic who has node positive disease, or a patient that has T4 disease, or really high grade poor performance status disease, that's a patient I'm going to be more inclined to offer sunitinib to, even if I think maybe medically they might be a little bit on the fence. They might be a little bit older, or they might have other issues. Can they really tolerate sunitinib for a year? I don't know. That's a patient I still want to have the conversation with, because there's even a greater risk of them recurring, and there's even a greater benefit associated with that adjuvant therapy.
Now, pros and cons. Patients with locoregional renal cell carcinoma at high risk for tumor recurrence after nephrectomy who were receiving adjuvant treatment with sunitinib had a longer duration of disease-free survival than did those receiving placebo. The safety profile in patients treated with adjuvant sunitinib revealed moderate declines in quality of life while receiving active treatment.
The most compelling data are the S-track study showing a disease-free survival advantage for sunitinib. We have to take those results with a grain of salt because there are other studies that do not show an advantage. And there are some real quality of life issues with sunitinib treatment compared to placebo. So it's not a slam dunk, but it is compelling and interesting, and something that we can pull out in people who are motivated to, prevent recurrence. So far, we don't have any home runs in the immuno-oncology space either for adjuvant therapy. But there may be more to come on that as studies mature.
Now, applications in medicine. In this randomized double-blind phase 3 trial, we assigned 615 patients with locoregional high-risk clear cell renal cell carcinoma to receive either Sunitinib or placebo on a 4 weeks on, 2 weeks off schedule for 1 year or until disease recurrence on an unacceptable toxicity or consent withdrawal. The primary endpoints include investigator assessment, disease-free survival, overall survival, and safety.
S-track is the adjuvant randomized phase 3 study comparing sunitinib with placebo in high-risk individuals with renal cancer who have had nephrectomy and in surveillance and follow-up. It's an adjuvant study. You get a year of sunitinib at 50 milligrams standard doses, and it's against placebo. And the trial shows a significant progression-free survival advantage statistically, with a hazard ratio of 0.76. The central review and the independent review are different from each other. The central review and the clinician's review, they're different in the results. One's significant and one's not significant. But essentially, the hazard ratios are 0.76 and 0.81, which are in the same ballpark as one another. And what that shows us is the results are marginal from statistical significance. One's just one side and one just the other side of significance. And that's really important. And there's no survival advantage in this study. The hazard ratio is 1.0. And that means we're not curing patients. Now, some people say that might be a bit early, but we've got a previous trial with Assure, similar design, which also didn't show any progression-free survival advantage, and also didn't show a survival advantage. And essentially what this is showing us is that while we're showing signals that may or may not be promising for progression-free survival, we're not seeing anything in overall survival. And patients obviously want overall survival. That's the goal of this, because in the adjuvant setting, we are going to over-treat a group of patients who don't relapse. And so therefore, what I would like to see before I start recommending adjuvant therapy is I'd like to see either a positive progression-free survival meta-analysis, so we can confidently say you can delay the time of the cancer to come back, number one, future trials that are positive, or an overall survival signal starting. And one of the issues in the way I look at that is that if we had a small difference, a trend towards a survival signal, that would be promising and would suggest there's a relationship between the two, of progression-free and overall survival. But because there's currently no relationship, it suggests to me that all we may be doing is just delaying progression-free survival, but not actually helping patients cure their cancer.
And now the conclusion of this topic is that among patients with locoregional clear cell renal cell carcinoma at high risk for tumor recurrence after nephrectomy, the median duration of disease-free survival was significantly longer in the Sunitinib group than in the placebo group, at a cost of a higher rate of toxic events. And thank you.